Now we will move to ocular prostheses. Reason why an eye may be removed are injury, infection, glaucoma, and tumor. Ocular prostheses are prefabricated eyeball for post-inoculation surgery. These eyes are fake one. It is not really a ball or globe. It is only a shell that covers the eye socket. Ocular prostheses can be also custom made for any patient using iris discs, cornea buttons, and acrylic white sclera. Steps involved in fabrication of custom-made ocular prostheses start with iris coloration before placing it over wax resembling the sclera. After molding in plaster and packing the white acrylic, the sclera will be painted with the matching color. And the final step, clear acrylic will be added to give the glaze of the conjunctiva. While the ocular prosthesis refer to the eyeball inoculation only, orbital defects involve the eyeball, the eyelid, and the surrounding hard and soft tissues. Eye exenteration and surgical closure will sometimes result in unfavorable orbital defect. When the resection is not confined to the orbit, or the defect is not deep enough to accommodate the prosthesis, this will end up with poor prognosis with the final aesthetic results. Orbital moulage can be obtained with different techniques. In this technique we have used the alginate. Over the alginate we place some gauze with some adhesives. Then we mix plaster with the slurry water, and after it gets set we can see the negative. The other technique to create facial moulage is to use polysulfide rubber-based material. This material, although it has long setting time, but it gives very fine details. This is the completed impression with the master cast. The stock prefabricated eye is positioned in the wax on the master cast. The stock prefabricated eye is reduced in size to fit within the confines of the master cast. An arrow is carved at the posterior surface of the eye to act as index during molding and wax elimination. After positioning the eye within the defect, the eyelid contours will be developed, and tongue blade is used to assess the interpupillary distance and level. After that, the surface texture will be refined. Shade selection is done by using the intrinsic skin color kit from Factor 2 company. Systematic color mixing is initiated and tried on the patient. Shade matching is one of the difficult tasks in maxillofacial prosthesis. The wax model of the orbit will be flasked. After flasking, the wax will be eliminated. You can see that the ocular part is moving. However, the index will help to reattach the ocular part to the cast. The silicone base after coloration will be mixed with catalyst 10% by weight and will be loaded into the mold. Curing depends on the type of silicone used. Some silicones are heat cure. At present, room temperature curing is the most popular technique. This is the completed orbital prosthesis. Eyelashes can be added, and the tinted eyeglasses may help to camouflage the edges of the appliance. This is another case with disturbed surrounding of the orbital defect. Facial moulage was taken by alginate and master cast is produced. This slide shows the ocular positioning and orbit waxing. The gaze of the eye or the tracking of the eye should be evaluated and adjusted while the patient is looking to the operator forehead. Intrinsic and extrinsic coloration must be done under corrected light condition, either next to the windows at noontime or under LED with high color index. Usually silicone facial replacement does not last for a long period of time. New prosthesis was fabricated after 2 years because daily use of the skin adhesives will deteriorate the prosthesis very quickly. The success of craniofacial implants for orbital prosthesis is quite high. The lateral portion of the supraorbital rim is dense cortical bone, and it can accommodate 3 implants. Care must be taken to avoid over-angulating the implants so it will not interfere with the prosthesis. At the second stage surgery, the implants are uncovered. Healing abutments are tightened and final impression is registered 3 weeks later. Magnetic keepers are connected together by tissue bar. The magnets are incorporated to the acrylic substructure. The final prosthesis secured in place with only magnet retentive mechanism.